Good morning, everyone, and welcome to SP 101, Preventing Despair, Understanding Behavioral Health Issues. To tee up our topic today, I pose you this question. Close your eyes and reflect on 2020. You know, the year we thought would never end. Did you change your life at all, or how did those changes make you feel? And how did you respond to those feelings? Did you have to work from home or cancel all these important events in your life, like vacations? Did you have the weirdest dreams and the worst heartburn of your life? Did you have to buy a Peloton or gain the COVID-19? It's okay, it's okay. Desperate times call for desperate measures. Please take a minute and share some of these feelings that you've had in the chat over the last year, and you'll see that you are not alone in living through 2020 with a few emotional changes in your life. So it was the snow globe of a year. Congratulations, you made it to 2021. As these times demonstrate, changes in these core parts of our lives are not insignificant. They can dramatically affect how we feel and behave. Behavioral health describes this connection between behaviors and the health and well-being of the mind, body, and spirit. In other words, it's how things like eating habits, stress, drinking, or exercising either promote or harm our physical and mental health. In addition to the changes in the last year, unfortunately, the epidemic has been credited for significant increases in reported depression and anxiety in children and adults. And sadly, there's been an increase in deaths of despair. And these are just a few of the examples of what we're going to cover today. I'm Carmen Hansen, Program Director for Behavioral Health and Pharmaceutical Policy at NCSL, and I will be your MC today. We have a star-studded lineup of NCSL experts with a broad overview of the latest developments on these important and often serious issues. And these issues are very serious, and they can be very personal and heavy, which not make them only difficult to talk about, but to address through policy. And we try to talk about these things in both public and private settings, and it can always be difficult. So with the question I started with earlier, behavioral health is different for everyone. And for some of us, these changes were major, and some of them were kind of like no big deal. But today we promise to give you a firm grounding so you can feel confident in understanding the latest in behavioral health topics and policies. This State Policy 101 series is an example of how NCSL strengthens state legislatures. NCSL is the only organization serving 7,383 legislators and more than 25,000 legislative staff. And we do this because we believe in the importance of the legislative institution, and we know that when states are strong, our nation is strong. Our services include research. We track more than 1,400 issues, from big issues to small issues. We kind of have something for everyone in there. We also bring together legislators and staff from both sides of the aisle to share ideas and solutions. And we have trainings and professional development tailored specifically for legislators and staff. And also, NCSL advocates on Capitol Hill on behalf of all states, fighting against preemption and for the 10th Amendment and maintaining federalism. And we have meetings. Whoa, do we have meetings? Our large NCSL Legislative Summit is our annual meeting, which typically happens in the summer. We won't talk about 2020, but we cannot wait to get out there and see you all in the real flesh, not in these little boxes, but at one of our over 100 policy-oriented meetings over a typical year. And here is our look at our topics for today. And we're going to cover some recent federal actions, behavioral health prevention issues, treatment and recovery, children's mental health, and a few more sprinkled in there too. And we have a lot of time saved for your questions. So following the presentations, we're going to have Q&A time, everyone's favorite. So be sure to put your questions in the chat, and we will get to those at the end, and we'll get to as many as possible. So without further ado, I'd like to turn things over to Haley Nicholson, NCSL's Senior Director of Health and Human Services, State and Federal Affairs, to start us off. Haley, the floor is yours.
Thank you, Carmen. Thanks everyone for joining us. I'm going to have some headphones in, and I apologize if there's any background noise. We're having some work done in the house, and this is work from home life. So I really appreciate your flexibility and patience. To get started, I wanted to open with a few stats. So in 2020, the Substance Abuse and Mental Health Services Administration, SAMHSA, received $5.9 billion in funding for the entire year, and that goes out to states and local organizations. And then at the end of December 2020, the most recent congressional appropriations and COVID relief bill was passed. The appropriations piece, SAMHSA received $6 billion in funding, but then there was an additional $2 billion in funding provided. So for the past year, there was this funding that went out, and then in 2 months, $8 billion, $2 billion more went out to states. So this was a significant kind of weight game and then getting a lot of different resources. So just something that I want you to think about as we go through this presentation and talk about some of the different funding streams. So as Carmen said, I'm Haley Nicholson, and I work with NCSL's State Federal Affairs team in our DC office. We look at different federal proposals, legislation, and see what the implications could be for the states, and do sessions like these to give you all an overview of what's been happening. So here is a brief overview of what I'm going to discuss today for the federal piece. And on this next slide, what we can see is a breakdown of funding, like I mentioned before, for SAMHSA, for behavioral health and substance use treatment. And so this funding will go, and it is broken down for things like substance abuse services, behavioral health areas, different programs like the Substance Abuse and Treatment Prevention Block Grant. And you'll also see that in the chat, we actually did just get some recent information on the COVID relief SAMHSA grants, and it's broken down by all of your states and organizational name. So please feel free to use that resource, and if you have additional questions, please let me know. So these are the top line overall funding amounts that went in. And as I said before, it goes for different things like community behavioral health clinics, suicide prevention programs, among others. Now, in addition to all the funding that was included in this bill, there were also some different policy provisions, and I've jumped a little bit for Carmen, I apologize. So on policy provisions, I wanted to talk about one of the more significant things that was in the bill was on strengthening mental health parity and substance use disorder benefits. I would like to ask the audience if you could put in Y for yes, N for no. Have you heard from people in your state about mental health parity? I'm always curious to know because it is definitely a popular topic. So knowing that this was included in the bill was significant. So what does this mean now? What this means is that group health plans and health insurance issuers are going to have to offer coverage in the individual that are offering coverage in the individual health group market, have to do an analysis looking at the non-qualitative treatment limitations they use for medical and surgical benefits and compare those to mental health and substance use disorders. The federal secretaries of Health and Human Services, the Treasury, and the Department of Labor will have to request at least a comparative analysis of 20 plans per year and look at any potential violations of mental health parity, including any complaints of non-compliance. If they find that a plan or coverage that was offered by an issuer is out of compliance with the mental health parity law, then actions have to be taken. The plans have to lay out what they intend to do. They have 45 days to implement that, and they have to notify their enrollees about the changes. So as you can see on this slide, there was also a few other policy provisions included around expanding access to Medicare for mental telehealth behavioral health benefits, and the extension of the community mental health services demonstration program, things that would take place in the states, and extending that through fiscal year 2023. So I'm talking a lot about federal work. It's good for me to touch on congressional trends. So here you can see in the behavioral health and substance use disorder space, this was a very popular topic in the last congressional session. It's definitely something that we anticipate a similar level of interest in these issues. And as we'll see in the next slide, it also can prove to be an area where policymakers at the federal level can work together in a bipartisan manner. It's something I really wish that they could learn from all of you about and take lesson. So when I talk about the congressional trends in behavioral health, one bill that stuck out to me that was introduced last session was called CARA 2.0. This refers to the Comprehensive Addiction and Recovery Act that was passed a few years ago by Congress. and was one of the more comprehensive addiction bills. So what the bill would do is authorize additional funding for things like researching opioids, mandating physician education on how to administer medication-assisted treatment and education on addiction, and creating a pilot program to study the use of methadone clinics in rural areas, among other proposals. I have not yet seen a reintroduction of the bill, but one of the co-sponsors, Senator Rob Portman of Ohio, he has announced that he is not running again for his seat. So this could definitely prove to be for him a legacy bill that he would like to get through. So as I'm going through these slides, remember again that for my job, I'm tracking things like this, federal actions, trends, and then informing all of you. So if you ever have questions on bills that you see, please let me and my team know. Now I want to talk about, I'm talking about Congress and bills. Here I want to provide a quick snapshot of the relevant House and Senate committees of jurisdiction. Here are the people in charge of the committees that basically look at any kind of aspect of behavioral and substance use disorder programs, treatment policy, and then of course there's also appropriations committees. I highlight these quickly because you might recognize some of these names from your states. And there have been a couple of changes, including ranking member Kathy McMorris Rogers in House Energy and Commerce has taken over that seat from retiring member Greg Walden. And then we've also learned in as of last week, there have now been Senate assignments done. So both in the House and the Senate, they've worked out their committee assignments, and that we anticipate they will start to kind of lay out what their priorities will be for the year. So when I referenced earlier, when it comes to behavioral health and substance use disorder, Congress can find this rare opportunity for bipartisanship. And one more example I want to share in the behavioral health space is the Support Act. This is quite the title, so be prepared. The substance use disorder prevention that promotes opioid recovery and treatment for patients and communities, the Support Act. I will clearly be calling it the Support Act for the rest of the time because that is quite the title. But the bill was passed into law in October in 2018. And this is a shining example of members in Congress working across the aisle. It was 250 pages that included new funding, additional support, and created new programs to address increasing issues with substance use disorder access, prevention, and treatment, and also related behavioral health policies. With the time restrictions we have today, and this bill being quite lengthy, I won't be able to get to all of the implementation pieces, but I'm always happy to follow up. Some things I wanted to highlight, you can see here, that they increased the treatment capacity of Medicaid providers that are working in substance use disorder treatment. And this included giving out 15 grants to different states. They've been conducting an ongoing assessment of substance use disorder treatment needs of the states, and doing things like providing grants to medical schools and teaching hospitals where they can develop a curricula that helps them prescribe medication-assisted treatment. It also gives flexibilities to providers like nurse practitioners and physician's assistants if they are also working and providing substance use disorder treatment. And finally, a more recent guidance that came out at the end of last year was for Medicaid to state Medicaid agencies on promoting coverage for at-risk youth. So with the time we have today, I won't be able to cover all of this, but happy to take your questions in the chat or after. I thank you again for everyone for your time. And with that, I think we can turn it over to my colleague, Charlie. Thanks, everyone.
All right, good morning, everyone. Thank you for joining us. My name is Charlie Severance. I'm a policy specialist in NCSL's health program, where I cover a number of behavioral health and public health topics. Today, my colleagues and I are going to touch on subjects legislators have been interested in that really span the entire spectrum of behavioral health problems. I'm going to focus my remarks in two areas that have been of particular interest to state legislators and their constituents: suicide prevention and the response to the ongoing opioid epidemic. Deaths by suicide and drug overdose deaths both fall into what some researchers refer to as deaths of despair. Both causes of death are associated with communities with struggling economies and a sense of hopelessness expressed by individuals who die from these causes. In 2016 and 2017, for the first time in modern history, the Centers for Disease Control and Prevention reported that US life expectancy was falling. The culprit the CDC identified was the incredible rise in deaths by suicide and drug overdoses. In fact, deaths by both causes rose so measurably that they offset falling mortality rates by nearly every other leading cause of death, like cancer and heart disease. Life expectancy rebounded in 2018, the same year that the US observed a leveling off and even a slight decrease in drug overdose deaths. This decrease in drug overdose deaths held in 2019, but unfortunately, rates of overdoses are rising again in the wake of COVID-19. But even though overdoses are on the increase right now, what we can take away from the improvements in 2018 and 2019 is that there are policy options and public health strategies that can improve health outcomes in these two areas. So today, for the first portion of our session, I'll use my time to provide a little more background into the prevalence and risk factors for suicide and drug overdoses, specifically focusing on opioid overdose in particular, and who is most at risk of dying by these causes. I'll ask you all now to think about who you think is most at risk of suicide, just in terms of age, profession, or where they live. You can share those in the chat if you'd like, and we'll dig a little deeper in just a moment. After we have that discussion, I'll use the remainder of my time to focus on the policy options that states have used to prevent deaths by these causes. And to begin, I'll focus on suicide in the United States. In 2018, the year for which we have the most recent and most complete data, there were 48,344 deaths by suicide, according to the CDC. This is up from around 47,000 deaths the year prior. Research has demonstrated that for every person who dies by suicide, there are 20 others who thought about suicide. So the CDC reports that there were roughly 10 million Americans who thought about suicide in 2018. Of these, about 2.8 million made a suicide plan, and there were 1.4 million suicide attempts. Outside of the emotional and human toll of these deaths, suicide and suicide attempts also cost the US $70 billion in direct medical and work loss costs. Unfortunately, suicide is also becoming more common. You can get a sense for the change in your state on the graph on the right-hand side, or rather the map here on the right-hand side of the slide. But the key takeaway is that since 1999, rates of suicide deaths have increased in every state except for one. In fact, in more than half of all states, suicide rates have increased by more than 30%. States with some of the largest increases in deaths by suicide include the High Plains states and the Mountain West states. But again, by looking at that map, you can kind of get a sense for the trends that your state has been experiencing. And to get back to that question of who do you think is maybe most at risk of dying by suicide, while we often associate suicide deaths with youth and young adults, it's actually middle-aged men who are most at risk of dying by suicide. Suicide is the fourth leading cause of death in this age group, and this age group accounts for the most deaths by suicide in the United States. For those over 75, their suicide falls outside of the top 10 causes of death for this demographic. This demographic does account for the highest overall rate of suicide deaths. Suicide is a major concern among young people still. Even though there is a smaller rate of death, suicide remains the second leading cause of death for those under the age of 25. Rural communities, communities with distressed economic conditions are also particularly vulnerable to suicide deaths. And we know that at an individual level, financial hardship is also a risk factor for suicide. American Indians and Alaska Natives have the highest rates of suicide deaths by race, and LGBTQ youth are another particularly vulnerable population. Veterans are another high-risk group. The Department of Veterans Affairs reports that an average of 17.8 veterans died by suicide every day in 2018. First responders and other professions like people working in mining, lumber, fishing, and other labor-intensive industries also have higher rates of death by suicide than the general public. Men are more likely to die than women by suicide across all age groups and races and ethnicities. In total, since 1999, more than 700,000 Americans have died by suicide. This number is remarkably similar to the 760,000 Americans who have died of a drug overdose since 1999, with these deaths being driven by the opioid epidemic. And so on that note, I'm now going to pivot a little and talk about the substance use disorders and provide a little background information on the opioid epidemic. As I mentioned on the previous slide, more than 760,000 Americans have died of a drug overdose since 1990. In 2018, roughly 67,000 Americans died of a drug overdose, which actually represents a decrease of about 4.6% from 2017. 2 out of every 3 drug overdose deaths that year involved an opioid. In terms of risk factors for opioid misuse and overdose, people with mental health or substance use disorders are at an increased risk of overdose. 18 to 25-year-olds have the highest rates of non-medical opioid use, including heroin. Men are more likely than women to abuse opioids and die of overdose, very similar to a suicide. Rural communities, again, are particularly hard hit by the opioid epidemic, as are communities with distressed economic conditions. So now that we've talked about the problem, I think we can move to sort of the brighter half of the presentation, which is what can we do and what have states already done? While I go over these strategies, I invite all of you to think about, or at least fast forward to maybe post-COVID when you get to resume those travel plans you canceled in 2020. And I want you to sort of pretend that you're out and about in a new city that you're not familiar with maybe a friend or a close partner, and you're afraid that they might be experiencing a medical emergency, like a heart attack or a stroke or something like that. And ask yourself, do you know who to call for assistance in that situation? And now I want you to imagine that maybe instead of a physical problem, you're afraid that maybe they're thinking of suicide or thinking of harming themselves. Do you know who to call in that situation? And we'll get back to that at the end of these strategies. But just think about it and maybe type some of your guesses into the chat. But the first strategy I've highlighted here involves suicide prevention, and it is commonly referred to as gatekeeper training. The idea behind the strategy is to train individuals who work with people at risk of suicide, teachers, for instance, to identify the signs that someone may be considering suicide or otherwise experiencing a mental health crisis, and to intervene with that individual. There are a variety of evidence-based programs available, and states have taken various approaches to using the strategy, such as requiring teachers to undergo this kind of training and other professionals who work with veterans or other high-risk groups. One such training is mental health first aid, which is an intensive training program to identify and intervene in people experiencing suicidal thoughts. There are a number of specialized mental health first aid trainings, including for youth and for veterans. And there are other evidence-backed programs as well, such as the Applied Suicide Intervention Skills Training, or ASSIST. This is the program that folks responding on suicide prevention hotlines will use. At least 20 states have enacted legislation relating to mental health first aid. Maine, for instance, requires all teachers in secondary education to undergo that training. Florida has provided an appropriation to local mental health agencies so that they can provide those training services in their communities. And North Dakota has actually created a voucher program so that communities that are maybe a little under-resourced can have access to these training opportunities. A similar approach is called the zero suicide. And this is an approach that is used in healthcare systems. Roughly half of everyone who dies by suicide visited a healthcare provider of some sort in the 4 months prior to their death. The zero suicide framework is about training healthcare providers to see the signs that someone may be experiencing some suicidal thoughts, and then training that provider on how to intervene with that individual, and then coupling that approach with an institutional commitment to getting that person into the care that they need, and then keeping that person in care as long as they need it. Colorado and Louisiana are the only 2 states that have enacted any sort of legislation in this area, and both states basically required their health departments to work with the healthcare sector to adopt the tenets of zero suicide. States have also enacted legislation targeting specific high-risk communities. For instance, some states have enacted legislation that allows for agency-level interventions among first responders and law enforcement, including leadership training on suicide prevention. Illinois, for instance, created the First Responder Suicide Prevention Act, which requires agencies like local police departments to provide training opportunities to identify the signs of suicide. This bill in particular also allowed individuals in local agencies to become peer support specialists, providing other individuals in that agency with a known sort of go-to person if they are struggling with thoughts of suicide. Kentucky has also created a law enforcement wellness program that incorporated aspects of suicide prevention counseling and some peer support services. Many people consider veterans' health to be a federal issue handled by the Department of Veterans Affairs, and the federal government does operate the Veterans Crisis Line, but states have also taken active roles in suicide prevention among veterans. Washington, for instance, requires all medical health professionals to undergo suicide prevention training specific to veterans, and Texas has established a trauma-affected veterans clinical care and research center. I should also note that NCSL has a specific task force on military and veterans affairs, which has a number of resources on state actions to support military personnel, veterans, and their families. These include resources for suicide prevention and substance use disorders. Among LGBTQ youth, there is a growing body of evidence that suggests supportive environments in school and the home are associated with decreased depression, suicidal feelings, substance use, and unexcused school absences. States have taken a number of approaches to supporting this population, For instance, in California, they've required school districts to include strategies specific to LGBTQ students in their suicide prevention plans. And Arkansas has clarified that the state's existing anti-bullying statutes prohibit bullying on the basis of sexual orientation. Workers in construction, extraction, and other labor-intensive industries also have higher suicide rates than other professions. The Construction Industry Alliance for Suicide Prevention recommends employers make suicide safety a priority by providing training to identify and help those at risk. They also advise raising awareness about the suicide crisis in construction and other high-risk professions, and normalizing conversations about suicide and mental health to ultimately decrease the risks associated with suicide in construction and these other high-risk professions. And then finally, in terms of suicide prevention strategies, at least, I'd like to highlight the National Suicide Prevention Lifeline and other crisis lifelines. These are generally a phone number that individuals can call to get immediate emergency counseling. Some states have created their own specialized hotlines. Colorado, for instance, has created the Safe to Tell program, which allows students to report suicide threats as well as instances of bullying or threats of violence. And Utah has created the Safe UT app, which allows you to text directly with a licensed counselor when experiencing a mental health crisis. And then to get back to that question that I first asked when we were starting to talk about solutions, in 2020, the federal government enacted the National Suicide Hotline Designation Act, which created a national 3-digit national lifeline. So if you're out and about in a city you're unfamiliar with and someone you're with is maybe having a heart attack or something like that, you would obviously call 911 regardless of where you were. So this hotline does a similar thing. It builds off the existing framework of the National Suicide Prevention Hotline with that easy to remember 3-digit number. States are also allowed but not required to implement a surcharge fee to support local call centers. This surcharge is equivalent to the fee states charge to provide 911 services. And I have just a few minutes left, so I'm now going to pivot one last time to take a look at some of these strategies that states can use to prevent opioid misuse and overdose, including prescribing limits, provider training, prescription drug monitoring programs or PDMPs, and naloxone and overdose prevention strategies. One of the most popular strategies states have taken is in creating opioid prescribing limits. These limits are based off of recommendations made initially in 2016 by the CDC and revised in 2019 based on studies suggesting that the risk of opioid addiction doubles after just 3 days on a prescription opioid and doubles again after 7 days on a prescription opioid. Legislators have enacted various limits in each state to ensure that unnecessarily large prescriptions aren't being made, but that individuals with chronic or acute pain needs can continue to access their medication. This legislation also includes recent developments like restricting concurrent prescriptions of opioids with drugs that can increase the risk of overdose, like benzodiazepines, or requiring a concurrent prescription of naloxone, the opioid overdose reversal drug, for opioid prescriptions of a certain strength and quantity. States have also enacted, and I think I've got more information on this on the next slide, laws requiring providers to undergo training around proper prescribing methods of opioids and also training around alternative pain management strategies. 49 states have created prescription drug monitoring programs, or PDMPs, which are essentially databases that doctors and pharmacists can check to make sure that they aren't prescribing or providing an opioid medication to someone who already has an opioid prescription or multiple opioid prescriptions from other providers. A practice known as doctor shopping. States are continuing to tweak these laws to improve uptake of PDMPs by providers. And finally, a very hot topic right now is naloxone, or the overdose or the opioid overdose reversal drug. Individuals experiencing an opioid use disorder may be at increased risk of overdose during the COVID-19 pandemic if they are no longer able to access naloxone, or if they're not using drugs with someone who may be able to administer naloxone. The biggest question facing state legislators right now is how to get naloxone to those who need it in the midst of the pandemic, and the perennial question of how to pay for naloxone. So New Hampshire actually created an opioid abatement fund, which will allow the state to reimburse any political subdivision for the cost of administering naloxone. The opioid abatement would come from potential money from settlements from manufacturers or distributors of opioids. And Virginia has appropriated $1.6 million directly from its general fund to purchase and distribute naloxone kits. And with that, I think that I am out of time. So I'm going to turn it over to my colleague, Tammy Jo Hill.
Hi, everyone, and thank you, Charlie. I apologize for the delay. That's just work from home here. But let's go ahead and jump right in as your last presenter today. So as Charlie said, my name is Tammy Jo, and today I'm going to highlight different components of behavioral health and some statistics for the general US population in 2019, as well as some treatment and recovery options. Then we're going to transition to some information around children's behavioral health. While we might think of them as tiny adults, their statistics and policy options tend to be different. And finally, I'll highlight behavioral health for both adults and children in light of COVID-19 and how this has shaped policy considerations throughout the last year and what we imagine will continue into 2021. I should also note that I would like to discuss actions for both 2019 and then compare them to 2020 where possible. I believe it's important to highlight those differences in years in terms of state action and policy, as we know COVID-19 really changed all aspects of our life. And as we go along, I want to encourage you to leave any questions and comments that you have for us in the chat as well. So presenters prior to me have discussed in depth what behavioral health is, and as not to rehash all of this, I just want to highlight a few distinct things that I think is really helpful when we're thinking about programs and policies. So first is that any mental illness is generally defined as mental, behavioral, or an emotional disorder. It can vary in impact from no impairment to mild, moderate, and sometimes severe. Examples of this can include anxiety, panic disorders, and depression. Any mental illness is most common, with at least 1 in 5 adults experiencing symptoms in 2019. While a serious mental illness is defined as a mental, behavioral, or emotional disorder that results in serious functional impairment, which generally can interfere with or limits one's ability to partake in daily activities or responsibilities that people might have in their day-to-day lives. The lifelong challenges of a mental illness are particularly concentrated among those who experience disability due to a serious mental illness. And we know that about 50% of lifetime mental illnesses begin at the age of 14 and 75 by the age of 24. A number of prevention programs and policies were mentioned prior, and something that we've tracked through legislation over the last several years. But we've also followed actions and policies related to behavioral health challenges through treatment and recovery programs. I recognize as well that this may not be a complete list of programs, so I invite you to share programs that you know work in your community within the chat box and with all of those on the line. To date, though, medication-assisted treatment, also known as MAT, is the most effective therapy. It combines FDA-approved medication with behavioral therapies such as counseling. 3 medications are currently approved by the FDA: methadone, naltrexone, and buprenorphine. In an effort to increase the use of these medications, the Centers for Medicare and Medicaid issued a reminder notice in October of 2020 to state Medicaid agencies that they must cover all forms of drugs and biologicals approved by the FDA for medication-assisted treatment as a mandatory benefit to be used for the treatment of opioid use disorder. As well, we've seen a call from a number of national organizations to expand further treatment and access by expanding the number and type of providers who can address substance use disorder challenges, as well as encouraging integration and collaboration between community supports and groups like first responders. And prior to COVID-19, many states had already worked to increase telehealth, mobile technologies, and e-prescribing. In 2019, Illinois did enact the Substance Use Disorder Act that now requires the Department of Human Services to reduce incidences of substance use disorder. They also worked to define substance use disorder for their state, design, coordinate, and fund prevention, early intervention treatment, and other recovery supports. States have also supported a number of recovery options. Since 2019, we've tracked at least 104 bills across 18 states that have addressed the creation or enhancement of different recovery models. A common model will include community supports, family supports, and sober living homes. Another we've seen a lot around our peer support services as an option for giving and receiving non-clinical assistance to support long-term recovery for substance use disorder. A peer recovery coach brings their lived experience of recovery combined with training and supervision to assist others in initiating and maintaining that recovery and helping them to enhance their quality of life and work towards longer term goals. We're often asked about reimbursement for peer support services. So right now we know that Medicaid will reimburse for services in at least 39 states, but it is an available option in all 50 states. Of the 39, at least 23 allow for support reimbursement for both individuals who have addiction and mental health disorders, 12 allow for mental health disorders, and 4 for addiction services. Another option that's been highlighted in the last few years and has demonstrated positive results in both adults and adolescents is family behavioral therapy. It combines behavioral contracting with contingency management, which is a system of low-cost incentives and rewards in exchange for participation in drug treatment or achieving personal treatment goals. Adolescents and at least one of the adults that they live with or a parent will participate in a treatment program and choose specific interventions from a menu of evidence-based treatment options generally. Then the therapist will work with the family members to look at behavioral strategies and skills that people can build as a family and as individual units to help them work towards long-term recovery. Children's mental health has also been a big area of concern for many states. Mental health disorders among children are described as serious changes in a way that a child will typically learn, behave, or handle their emotions. According to the Centers for Disease Control and Prevention, some examples of childhood and behavioral mental health disorders can include attention deficit and hyperactive disorder, behavioral disorders like oppositional defiant disorder, anxiety and depression, substance use disorders, and Tourette syndrome. Early identification of behavioral health disorders can lead to children receiving treatment sooner and help mitigate some of the challenges related to coping and resiliency later in life. Within a given year, an average of 7.4% of youth under the age of 18 in the United States have had a mental health visit in a community. However, studies have shown that children spend approximately 49% of their days in a school setting and are 6 times more likely to get evidence-based treatment when offered in a school than any other community setting. States like Arizona and North Carolina have recognized the connection between health services and offering them in a school setting. In the past year, they enacted legislation to this effect. Similarly, organizations like the National Center for School Mental Health have worked with a team of mental health professionals to identify core components of what a comprehensive school mental health system might look like. They found that by linking programs and supports that foster a school mental health system, states can not only reduce the number of children who might be experiencing anxiety, depression, and behavioral health disorders, but they can also save a considerable amount in economic costs by spreading physical and financial responsibilities from one agency to several. Finally, we have also tracked legislation that has included pilot programs that examine new or existing discipline practices and policies in public schools, appropriation bills for Medicaid services, and establishment of task forces to better understand the service landscape. And finally, different resolutions that will help address this within different branches of the government. House Concurrent Resolution 2 in Michigan declared adverse childhood experiences a critical health issue and committed the legislature to act and encourage the governor to direct agencies to assess and report progress on reducing adverse childhood experiences within their state. So as COVID-19 began to spread through the US and cities began to lock down, many public health and mental health professionals knew the dire state of mental health in America would only be exacerbated by changes to physical and social environments. While these changes can look different for everyone, some include changes associated with isolation or loneliness, financial hardships, housing, food insecurity, and sometimes interpersonal violence. These changes also highlighted health disparities or inequities in healthcare, health delivery systems, and health outcomes for groups based on social, racial, ethnic, sometimes economic, and environmental characteristics. We know in the first 9 months of 2020, screening for anxiety increased 93%, and screening for depression increased by at least 62% from 2019 overall. Throughout the year, our team has tracked state legislative trends and identified general policy considerations based off these state actions. States can consider the following options to improve access to behavioral health treatment and ways to help them leverage financial resources to improve behavioral health outcomes during the COVID-19 pandemic within their communities. As you can see, some considerations include supporting and expanding telebehavioral health services like Louisiana did by expanding their type of health providers who can perform telepsychiatry evaluations to include psychiatric mental health nurses as long as other requirements are met. Pennsylvania also passed legislation to continue access to naloxone by providing $947,000 for the state's naloxone reentry program, which helps high-risk individuals. And as always, we know that COVID-19 also continued to increase anxiety and depression for youth. Children also experienced that change in routine, learning, and access to healthcare. Like adults, they missed significant life events and had a loss of security, feeling of safety, as their families had to navigate job loss, inconsistent access to food, safe transportation, and housing. Screens for anxiety among children were up 9% from 2019, but more than anything, we learned that youth ages 11 to 17 were shown to be more likely than any other age group to score in that moderate to severe range of symptoms for suicidal ideations as well. I'm often asked, what can we do to help children during the pandemic? It's absolutely difficult when everybody is living in their home and locked down and not being able to see family or access health services. National organizations and agencies have published recommendations and toolkits throughout the year for adults to consider when helping children in their lives. Some of these considerations can include how to recognize and address fear and stress. And then for adolescents, also recognizing changing behaviors and how to discuss that with your children. And how to help children remain healthy by encouraging healthy eating habits, drinking plenty of water, and being physically active or learning a new hobby. Many of these recommendations highlight support for mental health for children, meaning that supporting them is by supporting them to achieve developmental and emotional milestones and learning healthy social skills and how to cope when problems arise. This was pretty high level for behavioral health and children's behavioral health, but it does highlight some trends that we have seen within the last 2 years and state actions around this. I'm more than happy to go in depth on any questions people might have on this, or please feel free to reach out to me with any other questions. I think with that though, I will turn it over to Carmen and hopefully we can have some Q&A. Thank you.
Thanks, Tammy Jo. There is so much going on with these issues, so we know it was probably a lot coming at you at the same time, or like in the course of this session. So we can really see how all sorts of behavioral health issues from childhood through adulthood have been affected. So we're getting ready to start our fantastic, everyone's favorite part of the session, which is Q&A. We have been dropping resources in the chat throughout the session, which you might have noticed, but don't worry if you've missed something. Our full resources document is available for download, which has I think it's about 30 or more links in there. There's all sorts of things. It's in the download. You can download it in the video player down by the speaker bios. And we have these longer policy briefs, we have short reads, we have riveting podcasts, databases, even more things like that, even short blog entries, which are a real quick snapshot of some really important issues that have been happening in 2020 and 2021. And you can also find our slide handouts in that same area below the screen. So now it is time for everyone's favorite Q&A. We have a couple questions that have come in. So I will start with one, it looks like for Charlie. We have seen increases in calls to suicide prevention hotlines during the pandemic. How are state legislators handling the intersection of these two health threats?
Yeah, unfortunately, we have seen an increase in folks calling suicide prevention hotlines. Thankfully, so far the evidence suggests that hasn't necessarily led to an increase in suicide deaths. But there are a number of things that public health officials and others are recommending right now. One of those is that while it is important maybe to maintain physical distancing from people right now to prevent the spread of COVID-19, many folks are encouraging people not to necessarily social distance, right? To stay connected through other means on social media, over Zoom calls, things of that nature. And you can absolutely also continue to promote resources that you already have, like the suicide prevention hotline, that can connect people to care directly in their neighborhoods. Tammy Jo also referenced a little bit of the telehealth measures that have been in place since the beginning of COVID-19. And there is a growing body of evidence to suggest that those measures or those treatment opportunities are, at least under certain circumstances, just as effective as in-person treatment. So we can continue to get folks into those different telehealth treatment programs and telehealth counseling.
Thanks, Charlie. Good to know that a lot of states are acting on this really important issue right now. We have another question. I think this one would be for Haley. What does a new administration mean for the states in these behavioral health areas?
Thanks, Carmen. So the administration has laid out, their priorities within different policy areas, including health and human services and access to behavioral health, recognizing that this is definitely an issue in a lot of communities. So what can federal partners do to help bolster resources, support healthcare workforce, and also have included about making sure that there's access for underserved communities, tribal communities. And so that's something that's been kind of broadly laid out. Once we get more information, there is an HHS Secretary nominee, Javier Becerra. Once his confirmation hearing is scheduled, and then once that plays out, once he can be put into that role, then it will we'll start to see a little bit more of the details of what kind of programmatic work, resources are they thinking. And also with his nomination, we're hopeful that once that hearing happens, we'll start to hear some names for a SAMHSA administrator, a person that would work very directly on these issues and work alongside him and help implement some of those priorities.
Thanks, Haley. Yeah, so many committee changes and everything else going on the Hill, and with the administration change and just congressional actions in general. So I know it's a lot for you to keep track of, so we really appreciate that. We have another question. It looks like this might be Tammy Jo or Charlie's area. We can maybe see if Charlie can start with this one. The opioid epidemic has unfortunately not subsided, and substance use and opioid overdoses have increased. What can you tell us about behavioral health issues and policy considerations for 2021? So we'll start with Charlie and maybe then Tammy Jo.
Yeah, absolutely. So unfortunately, we have seen an increase in overdose deaths since the beginning of COVID-19. This is kind of due to a number of things. If folks are feeling increasingly stressed right now, we've seen, just consumption of alcohol go up during the pandemic. That can lead to an increase in overdose deaths. We've seen that maybe the drug market has been impacted a little bit, and folks are not necessarily taking drugs that they're used to, or are now being riskier with the drugs that they're taking because they can't get the drugs that they're used to. Or maybe that they're just not using drugs socially, so there's no one around to administer naloxone if they accidentally overdose. So I think the biggest thing that I would highlight is that states are really concerned with how do we make sure that folks who need naloxone are getting naloxone. And that looks like, how are we funding naloxone programs? I mentioned the Opioid Abatement Trust Fund in New Hampshire, but also doing things like requiring a co-prescription of naloxone with certain opioid prescriptions. So it doesn't necessarily require that the person fill that prescription, but they have the option to get that naloxone with their opioid prescription. Tammy Jo, I don't know if maybe you've seen anything around telehealth services. I think you've referenced it a little in your presentation.
Yeah, thank you, Charlie. Absolutely, we have definitely seen a lot of changes around telehealth. And as I mentioned, states were working on this prior to COVID-19, but this definitely created the landscape for things to get passed a little bit easier, and for states to really focus a bit more financially in time on telehealth. So a lot of states we've seen recently working on how to expand the capabilities to different providers, both in state and out of state. Often it was a conversation prior that there were challenges that there weren't enough providers who were able to provide these services. So by opening up kind of the boundaries outside of your own state, it made it much easier for some states to get more providers within their area, and help folks that maybe live in more of a rural community. As well, we've seen a lot of other states work for reimbursement models and how that can shift with telehealth. So I know some states have had the discussion as well that this was maybe a temporary thing due to COVID, but I would say as of late, I'm seeing a lot more bills in this session that are addressing more long-term telehealth changes and regulations, as well as thinking about some of those reimbursement models for nurse practitioners or different levels of physicians in the telehealth space.
Thanks, Tammy Jo. It's really helpful. Another question came in think this one will be for Charlie. There's that new national 988 number that you mentioned. Can you tell me more about how what states might need to do with that? Do they have to take any actions with adopt this 988 or anything like that?
Yeah, it's a great question. So the national 3-digit number, the 988 number, is really based on the same idea as 911, right? And just like if you're calling for 911 in LA, if you're having a heart attack or whatever, you don't want an ambulance dispatcher responding in New York City, right? So these calls are best taken if they're taken locally, or at least at the state level. The current system, if it can't be answered at the state level, it bounces over to the nearest state to you. If it can't be answered there, then it bounces to a call center in New York City as kind of a last resort action. But those folks in NYC obviously can't connect you to a treatment facility or anything like that in your local community. So what this bill does at the federal level is it gives states to impose a surcharge fee similar to the 911 surcharge fee on your actual, basically on your phone bill. This is optional. It is not required of states to do this. So if it is something that your state wants to do, you have to start having those conversations now, because that does have to be implemented, obviously, legislatively.
Thanks, Charlie. Next question. Did somebody have anything else to add or to that one? Okay. We have another question here for Tammy Jo. You mentioned children's mental health was a big part of your presentation. COVID has highlighted the role of schools for being such a critical part of kids' lives. I mean, we know as adults it's hard to work from home, and for kids to do school from home, it's really hard for them too. So school plays that really important role of social emotional learning for kids. Can you describe the role that schools play as mental health care providers for kids?
Yeah, absolutely. Thank you. It's a great question. And I would say definitely, and even thinking just about the social aspect, if you're an only child, you're not getting the opportunity to see your friends and run, play, let alone if you're not an only child. I have many siblings, and it wasn't always fun to just always be in the house with my siblings. But as far as mental health goes, schools have the great opportunity to connect children with evaluations or screenings or nutritional services, or help connect them as well with therapists. So, as I discussed, kids spend 49% of their days or something in schools, and that's just in a given year. Think about if you're doing any kind of summer schooling program, or you're spending time with physical activities or things, throughout your breaks, you're there a lot. They also have the ability for kids to make that connection outside of their home, whether it's with other children themselves or with the adults that they're seeing in that day-to-day space. In the past, this has really enabled educators or administrators or folks within a school setting to help identify children that may be experiencing potential abuse or neglect, as well as helping children that may be experiencing hunger or homelessness. So having that connection is very important for not only their social and emotional learning, but to make sure that they're connected to services that they might need and they may not be able to express. So also connecting with those adults that can see, hey, I see that you're having a really difficult day to day. Would you like to talk about that? And sometimes it's much easier to do with an adult that's not your parent. So I think schools really open up the avenue for children to be able to connect on many different levels.
Thanks, Tammy Jo. I've a couple questions left. Haley, could you talk a little more about the Support Act and elaborate on any of the challenges that are regarding that Support Act? It is such a huge piece of legislation.
Absolutely, Carmen. If folks do have questions, like there's so much in there. But a couple of the challenges they faced are states that had applied for waivers for people that kind of fall under with needing substance use disorder treatment and related behavioral health. Some of the waivers that kind of would have fallen in line with what was in the Support Act had not been approved or been partially approved. So I know some states were still waiting on a final answer. There was also an federal interagency group that needed to be formed to kind of look at all these different programs and come up with recommendations The group is now formed, but it definitely was delayed in getting put together, and they still haven't scheduled a public meeting yet. So things like that. And then also there has been last year and after the passage, kind of constant requests from congressional folks asking different agencies that were outlined in that law about things that they needed to do and next steps, asking for reports that were required, providing additional information, and sometimes not always getting that. And so I know that's something that congressional leaders are going to continue to pursue and ask for. So really an implementation, there's definitely some places that there's been a big stall in some areas.
Thanks, Haley. We have, I think, 2 last questions coming in. If we have, if anyone wants to add another one, feel free to add those in the chat. One question is, how often, and this I think Tammy jokes about schools again, how often do you work with Children and Families Department at NCSL, because there's so much overlap with our topics regarding things like social work, foster care. What about those wellness checks that people have been doing for kids that haven't been maybe part of school and things like that lately? And that vital connection of teachers being a way to report any potential harm that kids might be going through. Can you talk about that a little bit?
Yeah, absolutely. I think that's the great thing about NCSL is that we have many teams that we can partner with. So absolutely, Children and Families Department helps to work on social work and foster care, but then we also have our education team that really focuses on that social emotional learning piece. So I think that for the most part, all of us work really well together about trying to address the different challenges that we see, and absolutely the decrease in children not receiving, that attention from schools and teachers, and potentially not getting those wellness checks. So I would say that, that's going to cross many teams for us, but we are in constant contact about what states are doing and how they're addressing it, and thinking about, the different agencies and groups that states can then work with. So, if you are working with a social work team or maybe foster care, but you're also interested in mental health, we kind of foster that kind of conversation between our 2 teams and can provide examples and policies that have crossed different agencies within states. So I think for us at NCSL, it's just as important of how we talk to one another as a team as maybe, states do as far as executive agencies and legislative branch.
Thanks. Yeah, I know some of our programs can be cross-pollinating with maybe even 4 different programs at one time for one information request, because it might have that the systems funding, it might have a federal funding part or a state tax part component. It's really fun to be able to work across all the different programs to make sure we have really comprehensive answers for our members. So thanks a lot for that, Tammy Jo. And we have one last question, I think, for you, Tammy Jo. Let's see. You briefly mentioned on one of your slides, recovery high schools. Can you tell us more about what those are and if those are even available at a higher education level?
Yeah, absolutely. Recovery high schools are kind of a unique model that I actually got to learn about through this job. So I think it's really interesting to hear how many states have looked into it. Specifically, a recovery high school is designed for students that are recovering from a substance use challenge or disorder. They're typically part of a general school setting or maybe set as an alternative school program within a public school system. But the goal of the recovery program is for students who are separated from folks that maybe aren't going through the same experiences they are, and with people that are. So think very much like that peer recovery model. You're learning from one another, you get to relate and understand each other's experiences. But the program specifically allows for these students or youth to be together and discuss, how their challenges are affecting their day-to-day life, what kind of treatment options providers have, and they're also enrolled at the same time in school and treatment recovery programs together. So it's kind of a bonding force for youth that are going through this together at the same time, but still in a school setting. We know that in 2019, Massachusetts actually introduced 4 bills around recovery high schools and how to expand those services. And then speaking about universities and higher education, this program has been around for several years. And since at least 2013, I believe, we've seen a growing number of programs on university and college campuses that are very much the same, where it's youth coming together to work through substance and recovery with one another. And as of late, I think there's about 136 nationwide collegiate recovery programs. And so those models will obviously look a little bit different than recovery high schools, but I think the goal is very much the same in assisting youth through these behavioral challenges.
Thanks, Tammy Jo. Technical difficulties, of course, are going to happen right at the end of the presentation. So I just wanted to say thank you, everyone, for your presentations today, our NCSL in-house experts, Haley, Tammy Jo, and Charlie, and as well as everyone else on the back end of things today, our fantastic meeting program, who has really had such a huge job with switching everything from our in-person formats to these virtual formats. We've really appreciated everything you've done with us, and all our other folks who have helped us set these things up, and all the other folks behind the scene in our program, like Colleen and Noah and Elise, everyone. It's a really big team effort here at NCSL, and we appreciate that. So if you have any other questions for us, please do send us an email to that health-info@ncsl.org email address, and we will send those emails out to the right expert for you. And if you have any other questions, just use that for us, and we'll get right back to you. So I just want to say thanks, everyone, for taking time out of your very busy days in January during sessions to sit and hear a little about Behavioral Health 101 with us. And again, everyone, take care, be safe, and we will see you all hopefully in person soon. Thank you.